Right. So here we start. What is seen here?
Dilated ventricles, hydrocephalus.
Dilated ventricle in a MRI or a CT scan.
CT brain.
CT scan showing obstructive hydrocephalus. Very good. How to find out the CT image from an MRI image? How to differentiate?
So the bone window. CT we can clearly delineate the bone window. So MRI soft tissue enhancement.
I am showing an MRI picture here. What is the main difference between the two?
The fluid color difference.
Fluid
Black
appears white in T2 weighted MRI, whereas it appears black in CT scan. Okay, that is the main. So if you see a black colored ventricle filled with CSF, it is CT. If it is white fluid in the ventricle, it is MRI. Okay, that is the easiest way to identify. What are the types of hydrocephalus?
Communicating and non-communicating hydrocephalus.
Very good.
Obstructive and communicating.
Chronic, non-communicating, and communicating. Mention the causes of hydrocephalus.
Arnold-Chiari malformation.
Okay. Can you classify them like congenital, which are vascular malformation like Arnold-Chiari, arachnoid cyst, meningocele, stenosis of epididymitis, and idiopathic. These are all congenital. Then you can acquire. It can be due to hemorrhage, infection, nutritional, trauma, and tumor. Okay, so you always classify the causes of hydrocephalus. Even in practical viva, if they keep a hydrocephalus patient and ask you the etiology, you have to divide into congenital and acquired causes. The acquired causes are hemorrhage, infection, nutrition, and trauma. You can remember as HINT, HINTT, HINT as a mnemonic for remembering the acquired causes. And what is Hakim's triad? What is the other name for this condition?
Subarachnoid hemorrhage, sir.
No. This is called the Hakim's triad, also known as Adam's triad, which is described in patients with normal pressure hydrocephalus. They have three problems: weight disturbance, dementia, and urinary incontinence, which is described as because they have urinary incontinence, they are wet, and because they have weight disturbance, they are called wobbly, and because they are dementic, they are called wacky. So this is a normal pressure hydrocephalus, especially you can see in elderly patients. How is hydrocephalus treated?
So it is shunt procedures can be done. So either
You can divert the
Ventricular-
fluid.
VP shunt or
Or
ventricular shunt?
Primary treatment is surgical with ventricular shunt placement or CSF diversion by ETV. What is ETV?
extraventricular flow.
Extraventricular. Endoscopic third ventriculostomy. Okay. So you put a tube by endoscopy through the nose. Puncture the third ventricle and drain the fluid. Okay? Then flexotomy are often shown treatment of hydrocephalus. The 35-year-old hockey player sustained a fractured shaft of femur and has undergone intramedullary nailing under subarachnoid block. On the third post-op day, patient complained of sudden onset of breathlessness. Oxygen saturation dropped to 82% in room air and patient was disoriented. High flow nasal oxygen started and ABG sample obtained. This is the value of ABG. pH is 7.52, PCO2 27, CO2 65, bicarb 18, and base X is 1.2, oxygen saturation 92%, sodium, potassium, chloride values are given. What is the interpretation of ABG values?
Respiratory alkalosis.
Is it primary respiratory alkalosis or secondary to embolic acidosis?
Secondary to acidosis.
See, bicarb is low, 80,
Yes, sir.
and base excess is a minus 1.2. So, this is a alkalosis, which you want to low respiratory,
So,
but
why many?
low acidosis. So, you must use the formula to find out whether the change in bicarbonate is according to the clinical condition. So 0.2 into 40 minus 27 minus 13, 2.3. So expected bicarbonate is 21.4. But the bicarbonate is lower than that. So it is not a primary respiratory problem. It is a primary metabolic acidosis. With because of hypoxemia, patient has developed acidosis, which is compensated by respiratory acidosis. Okay, so that is the interpretation. What could be the cause of this sudden change in the patient condition?
Fat embolism.
Fat embolism, very good, long-term bone. Fat embolism syndrome, which is common after long bone fracture. How is fat embolism diagnosed? If this is fat embolism syndrome, what are the points to confirm your diagnosis?
Fever, tachypnea.
Presence of petechiae, hypoxemia.
What are the triad? Three things which are very classical and pathognomonic for fat embolism. GERD's triad,
Respiratory insufficiency and cerebral.
neurological, respiratory, and cutaneous manifestations, which are called GERD's triad. Fat globules in urine also can be demonstrated by urine examination. But these three are altered sensorium, tachypnea with desaturation, and petechial hemorrhages in the skin of the classical representation of fat embolism. In the Bergman's triad, dyspnea, neurological impairment, and petechial crash. What are the theories proposed for fat embolism syndrome? Two theories have been proposed. What are the two theories? Okay, one is called mechanical theory, where other is called the biochemical theory. And in mechanical theory, what happens? The fat globules inside the marrow are forced through the open venous channels which are there in the supplying the bone. So that is called the mechanical theory. Intramedullary pressure rises, which forces the fat globules in the bone marrow to enter the venous channel, which come into the systemic circulation. Whereas biochemical theory is the stimulation by the cytokines. Okay? And, how is this condition treated? How do you treat once you make a diagnosis of fat embolism? How do you treat the patient?
The supportive measures.
Yes, it is mainly supportive with ventilation, fluid resuscitation, including albumin. Okay? All what you have to do. What is seen in this EKG?
It's inferior wall MIs. Elevation
MI. Okay. What about the V1, V2? These are all ST elevation in Q3 and AVF. Okay, as in well. But V1, V2, that's a ST depression. So how do you describe that? Each tooth reflect change in the tooth infarction of the inferior. The ST elevation developing with a Q wave. The concurrent posterior wall of ST depression in this case. Okay, so this also you should not miss these two changes. Which coronary artery is involved in this patient if it is acute infarction?
Left anterior descent.
Anterior descent.
Posterior wall in my left coronary.
Right posterior.
And inferior.
Posterior interventricular.
Inferior MI is due to occlusion of right coronary artery, okay, not left. Left is anterior descending nerve. That will be seen mainly in the V3, V4, V2, V3, V4. Okay? That is a left coronary disapply area. What conduction abnormalities may happen in this condition? If the patient has a right coronary occlusion, what conduction abnormality can happen?
The AV block.
Yes.
AV block. Bradycardia secondary to AV block and complete heart block together with junctional escape beats can happen. Okay? Very good. So bradycardia, because sinus node can be mostly supplied by right coronary. The patient can have a bradycardia. Now I'm showing you some chest lead changes. ST elevation more than 1 mm, positive T wave, no ST elevation, positive T wave, negative T wave. See, this is a negative T wave. So there are three types of presentation of chest leads. So what is the interpretation based on these STT changes? The first two, T wave is positive. And in the first one, ST segment also is elevated. The second, there is no ST elevation and T wave is positive. But in the third, T wave is inverted and ST is not isolated. These are all with regard to coronary occlusion, right coronary occlusion. Now, can you answer this?
Myocardial infarction.
Sir, ST elevation in more than 1 mm showing hyperacute change, sir. Immediate
No, no,
presentation.
I'm asking about if these changes are present in the V1 or V2 and there is evidence of right coronary occlusion as seen in lead 2-3 AVF, which level of occlusion these things depict at the right coronary artery? Proximal, mid or distal. These are the three levels that can happen, you know. So
Yes.
ST elevation with a positive TA, proximal occlusion of right coronary artery. No ST elevation with a positive distal occlusion of right coronary artery. And if it is a negative T wave, it is a right circumflex occlusion. Okay, so these two are proximal and distal occlusion of main right coronary artery. Negative T wave in chest leads, distal occlusion of circumflex, occlusion of right circumflex artery, which is a branch of the right main coronary artery. Okay. So how to treat? If you have diagnosed acute inferior wall infarction, how do you treat this condition?
So the loading dose can be given, sir.
Loading dose of what?
Aspirin 300 milligrams and P2Y2 inhibitors, clopidogrel 300 milligrams with a statin. If hemodynamically stable or unstable, we can treat accordingly, sir. If unstable, we should start an inotrops and subsequently go for a coronary revascularization procedures. It's a golden period. PCI.
PCI is the patient is having acute coronary syndrome. So this is STEMI, ST elevation. So proceed to PCA. Straight away go for coronary occlusion. Because all this oral treatment can be given. But the mainstay of the treatment is early revascularization. If it is a non-ST elevation MI, how do you treat? This is a classical ST elevation MI. You can see how elevated these segments are. So if it is a classical ST elevation MI, earliest PTCA is the answer. But if it is a non-ST elevation MI, what is the treatment?
Antithrombotic agents can be given.
Antiplatelet therapy, anticoagulation therapy, and angio at the earliest. What is the ideal door to balloon time? That is
90 minutes.
90 minutes.
90 minutes. Excellent. Now we are shown here two methods of holding the laryngoscope. When do you do this?
For pediatric.
Pediatric. Okay. This is for pediatric and this is for adult.
No, sir. The angle of
See, look at the blade, look at the
Straight
fold,
blade.
everything you have to move. Okay? So holding the laryngoscope near the blade like a pen compared to standard grip used when intubating adults. So this is for mainly newborn and infants. You use the laryngoscope like this. Hold it like a pen and you are using a straight blade, which indicates that it is for a infant or a newborn. Whereas if you are using a curved blade, you are holding it with the distally at the handle, it is mainly for adult intubation. What is being shown here?
scissoring method of opening mouth.
Ah, fantastic. Scissors, trick of opening the mouth. And the next one,
Tongue.
pressing the tongue. Yes, scissor opening of the mouth in older patient, opening the mouth by placing your finger on top of the tongue in a neonate. Okay, so in neonate you can't do the scissor opening. So there you put your finger and press the tongue and open the mouth. What is shown here?
External laryngeal manipulation is done.
Backwards, upwards. Sir.
Okay, but why two pictures there?
Sir, using single
Different
angle
type of
grip and
blood.
using double
The operator himself is using this little finger while holding the laryngoscope in small infants and neonates. The operator himself can give the laryngeal external laryngeal pressure using his little finger. Whereas for older children, you require other person to give the compression, burp man. Okay? So external laryngeal manipulation applied using little finger of left hand in neonate and right hand in older patient. Okay? So you can do it with the if somebody identify this correctly and answers correctly, they require they can be given a treat. Let me see who is the best in that. Look at the picture carefully and answer. Please
micro.
identify what are all the things that you are seeing. See, you are seeing something here, and you are seeing another thing here. What are the two things?
Un
And
Uncup-
ET tube.
Huh?
ET tube with a catheter.
Suction catheter passed into that. Okay, this is the tip of your suction catheter. It can be attached to a suction tube. Okay, this is the catheter tip. This catheter has been introduced into the ET tube. What is the purpose? When do you do that?
It helps as a conduit, like bougie.
Yeah. Why should you use this?
And
Small
thoracic
children, when you want to do which route of intubation you do this? Oral or nasal?
Nasal,
It is done for nasal intubation. Suction catheter inserted into endotracheal tube to help pass down the nose without trauma. This catheter will first go in and dilate the passage. Then you push the endotracheal tube and remove the catheter and advance the tube into the trachea. Okay, so in small babies, neonates, to avoid injury and bleeding, use a small size catheter. It is inserted into the tube, railroad with the whole thing into the nose. Okay. How is total body water controlled? What is the percentage of our body water in our adult body?
70,
60% of
65
total
to
body
70.
weight.
60%.
60% in
For a 70
females.
kg man, how many liters of water will be there?
42 liters.
42 liters. Okay. Out of this, how is this 42 liters level controlled? What are the mechanisms? You must drink water and you must pass water as urine. Isn't it? These are the two mechanisms. How they are controlled?
First
First,
mechanism by mediation.
integration of three components: sensors, osmoreceptors, volume receptors, and high pressure baroreceptors. It changes in fluid osmolality and total body fluid. These are the three things. So these messages are received by hypothalamus, which is integrated to react, increase or decrease the water. So thirst helps to increase water intake and ADH regulates water output. So these are the three mechanisms that is how body water is controlled. Which cell membranes are impermeable to water?
Cells
Cell
with tight
membranes,
junction.
the membranes lining some organs in our body, they don't allow water to permeate or go.
Astrocytes and
Astrocytes.
blood-brain.
Bladder epithelium, ascending loop of only cortical medullary collecting ducts. Okay? These are all the three things that are impermeable to water. What is the definition of a crystalloid and a colloid? Crystalloid are the made up
Crystalloid will
of
give only
small particles or
hydrostatic
large
pressure.
particles?
Crystalloids will provide only hydrostatic pressure, where colloid will provide colloid osmotic pressure with the help of proteins.
Fusion with small molecules which dissociate into ions which can pass through semi-permeable membranes are called crystalloids. Solution with small molecules which dissociate into ions which will develop an electric charge. For example, sodium chloride or NaCl. It becomes sodium ion and chloride ion. It can pass through semi-permeable membranes. Whereas colloids are solution with larger molecules dispersed in a solvent, and they do not pass through semi-permeable membrane easily. So they draw water or they cut fluid from outside and they expand the volume inside the vascular. How much fluid will be retained in the vascular compartment when 1 liter of sodium chloride or 5% dextrose is infused? That is, we have to tell the value for both 1 liter of NaCl and 1 liter of 5% dextrose. If you infuse these two in two different persons, how many ml will be retained? 1 liter is 1000 ml of sodium chloride, or 1 liter 1000 ml of dextrose is infused. How will you know how much will be retained in the vascular compartment? One of the FRCA questions asked in the fellowship examination in UK.
Only 20%.
You must tell me in exact milliliters out of 1000 ml of sodium chloride, how many milliliters will be retained inside the vascular compartment? And out of 1000 ml of 5% dextrose, how many ml will be retained after you complete the infusion of the whole fluid? This is, let's say, NaCl is isotonic. We distribute among extracellular compartment. So, out of the total body water, 2/3 is intracellular, 1/3 is extracellular. The extracellular is divided into intravascular and interstitial. So out of that, only 25% of extracellular compartment is intravascular. So 750 ml will go into the 2/3 is 660, out of which balance will be 25%, which will be in the extracellular compartment, out of which 250 ml will be retained in the vascular compartment. Whereas for 5% dextrose will be immediately metabolized and it will become only 100,000 ml of water. This is hypotonic. And this water will distribute equally into the total body water, which is 2/3 intracellular, 1/3 extracellular. So 333 ml in the extracellular, out of which 25% is intravascular. So 333 divided by 4 is 84 ml. So if you give 1 liter of sodium chloride, 250 ml will be retained in the vascular compartment. Whereas if you give 1 liter of 5% dextrose, only 84 ml will remain inside the vascular compartment. It will only help to hydrate the interstitial and intracellular compartment and not intravascular compartment. Okay? That is why 5% dextrose is not considered a fluid for resuscitation purpose. Right? How is fluid moved from compartment to compartment? What factors govern the movement
Pressure,
of fluid in one compartment?
Osmosis
pressure gradient,
and
pressure.
concentration gradient.
Concentration
Darling's
rate.
forces.
By a combination of osmotic and hydrostatic pressures. Okay? The osmotic pressure results from difference in solute concentration across cell membranes. The hydrostatic pressure results from the pressure of blood as it enters the capillary system, forcing some fluid out of vessel into the surrounding tissues. What is shown in this picture?
Hypoxic pulmonary
Vasoconstriction.
vasoconstriction.
Hypoxic pulmonary vasoconstriction. You can see the vessel is constricted. It is insulted. And this is the hypoxic alveolus. So it is self-explanatory. Right. Describe hypoxic pulmonary vasoconstriction. What is the definition?
So it is a protective mechanism which decreases the shunt.
Very good. It's a protective physiological mechanism that moves the blood away from the hypoxic or collapsed alveoli to better ventilated alveoli for maintaining. So low alveolar oxygen tension is the main reason for the reflex vasoconstriction to happen in the arterioles. It is the alveolar oxygen tension and not the blood oxygen tension which is the cause for the vasoconstriction. So this is possible by reduction in levels of nitric oxide, which is a vasodilator, and the inhibition of oxygen-sensitive potassium channels, which cause depolarization by increasing the calcium and smooth muscle contraction of the vasculature and a vasoconstriction. So this is a biphasic response, initial period of increase in pulmonary vascular resistance, followed by a more sustained phase of vasoconstriction. So this is an unusual response compared to systemic circulation where hypoxia will result in vasodilation. All these points are there. What is the significance of this hypoxic pulmonary vasoconstriction?
Which decreases the shunting
Content. Okay.
and improves
Early
oxygen.
LVH subventricular failure. Hypoxic pulmonary vasoconstriction is responsible for diversion of blood from the lower lobes to the upper lobes, so that patient will be able to maintain oxygenation, especially in left ventricular failure where there will be congestion in the basal lobe. You will start getting the valves and leave the lower lobe first, then only it will spread. So there blood flow more and it is diverted. In chronic lung disease, it causes pulmonary hypertension leading to pall pulmonale and later on right ventricular failure. In cardiac shunts, hypoxia leads to increase in pulmonary vascular resistance, aggravating right to left shunt. And in fetal pulmonary circulation, low alveolar O2 is responsible for hypoxic pulmonary vasoconstriction, increasing pulmonary vascular resistance and decreasing blood flow through the non-functioning lung in the fetal circulation. And at a high altitude, this will cause significant increase in pulmonary vascular. Importance of HPV to anesthetists. Which particular anesthetic technique this plays a very important role to prevent hypoxia?
One lung
One lung
ventilation.
Ah,
Microscopic
factors
surgeries.
including HPV, like high FiO2, volatile and agents, including nitrous oxide, is important in lung anesthesia. When we talk about one lung anesthesia, there is a picture shown, something related to one lung anesthesia. Can we identify what are all the things that are shown by the arrow marks? The picture clear? Slightly hazy, but
Yes,
not a
sir.
very good quality.
It's a double lumen tube with
double lumen tube, sir.
So the arrow marks, yellow arrow, the blue arrow, and purple arrow, all the things.
it's a right
Okay.
side DLT which has
The
an
bronchus
fenestrated.
has double lumen endotracheal tube. The distal orange arrow is inserted into the trachea until the bronchial lumen, that is the blue arrow, has entered either the right or left main bronchus, whereas the tracheal lumen remains above the carina. Okay? So, it's the whole electrical tube. It goes in, you advance till you encounter a resistance. That means you have entered the division of the trachea and the major bronchi. You stop there, and that is how you see that. What is this picture showing? You have passed the W1 tube. How do you confirm the position?
With fiber optic.
Fiber optic. So this is the bronchoscopic view of the carina from inside the tracheal lumen of the W1 tube. You can see the distal tip of the W1 tube entering the left main bronchus to enable single lung ventilation. Okay? So you can see the tube goes inside. What is this?
Confirmation of one lung ventilation.
Ah, yes. The clamp is placed on one limb of the ventilation circuit, allowing selective ventilation of the opposite lung. So to identify whether you are able to ventilate both the lungs or one lung, you apply the clamps to the W connections. What is this monitor showing?
A rise in EtCO2, hypercarbia.
Hypercarbia in one lung ventilation. Okay, cardiorespiratory monitor during single lung anesthesia ventilation, entitled CO2 elevated to 53 because of decreased ventilation, whereas oxygen saturation is maintained at 99%, blood pressure remains stable despite single lung ventilation. So initial stages it will be maintained. So only when it starts dropping, you have to do all maneuvers to maintain the oxygen. What is shown here?
Patient with burns.
What are all these things? Incisions, you see.
Discharge and
Discharge formation.
Discharge means everything, all black tissues should be removed. Here you see a vertical splitting. Don't you see that? Long incision.
Fasciotomy.
Fasciotomy, yes. Patient who has sustained deep burns to upper limb, face, and head. What are the challenges in providing anesthesia for extrarotomy in this patient?
For hysterectomy, there will be bleeding and major fluid shifts, sir. So IV access is difficult and
Well, what about the airway? The neck, everything face. Can you ventilate this patient in a normal way?
difficult mask ventilation.
So this appears to be a major burn. So check for adequate food and unstability, patient airway evaluation, investigate results for CBC, electrolyte, urea, EKG echo, parameters you have to check for consciousness, heart rate, BP, respiratory rate, urine output temperature. Optimize the patient based on investigation results with fluid, blood, electrolyte correction, renal function test, and temperature maintenance. Pre-op Keep the patient NPO, give acid aspiration prophylaxis, antibiotics, blood reservation, and difficult areas. And intra-op difficulties may be encountered in positioning, plus mask ventilation plus airway may be challenging. Monitor placement may be difficult. IV access may be difficult. Need of drugs like analgesics and neuromuscular blocking drugs may be increased. And you have to avoid hexamethonium if the burns is more than 24 hours. The increased blood loss, hypothermia, and sepsis are all the complications that you get. So, post-op, you have to give adequate analgesia. You have to maintain circulatory stability, preserve renal function, maintain normothermia, prevent infection, start early enteral feeding, maintain electrolyte status. Post ABG of this patient shows pH 7.21, PCO2 45, bicarb 15, base excess -3. What should be done?
Combined respiratory and metabolic acidosis.
Combined 45, is it acidotic? PCO2 45, 35 to 45 can be normal.
The severe metabolic acidosis.
Interpretation ABG 1.21 is acidic, PCO2 45 is normal, bicarb 15 acidosis, base excess 8 is acidosis. So this patient is in an uncompensated metabolic acidosis. The PCO2 cannot be normal. Normally, you should have the compensation by tachypnea and patient should wash out. So expected PCO2 is equal to bicarbonate multiplied by 1.5 plus 8 Winter's formula. So it should be 30. And the measured value is 45. So even though 45 appears to be normal, patient is in respiratory acidosis also. So this is how you include the patient is also in respiratory acidosis, not by merely looking at the PCO2 value. Okay, so you must always use this formula to see what exactly should have been the carbon dioxide. So PO2 is 120. Since FiO2 not given, we have to presume that she should be on supplemental oxygen, as 120 not possible with air. So if FiO2 is 40%, then PO2 is low for that also. If the FiO2 you are giving 40%, what should be the PaO2? FiO2 PaO2 ratio.
240.
5 times. No, normally when you are breathing 21% oxygen in room air, your PaO2 is 100%, 95 to 100.
300.
So roughly about 5 times, but at least 4 times it should be there. So for 40%, you should have a PaO2 of 160. Okay, so this so much of interpretation has to be done with this ABG report. Stop with that. I will just finish after this. What do you infer from this picture? What is the expansion for this alphabets?
Essay units, sir.
Very good. SI units. The 7 symbols of 7 fundamental SI units. What are the 7 fundamental units?
Meter, seconds, kilogram, temperature Kelvin, current ampere, candela light intensity,
Mole.
moles,
S second, M meter, mole, A ampere, PV candela, A Kelvin. What are derived SI units? How are they classified? Enumerate them. These are all 7 fundamental. From this
Yes,
fundamental, you can have some derived SI units. They are obtained by multiplication or division of the fundamental units. They are classified as electrical and non-electrical derived units. 4 electrical derived units are volt, ohm, coulomb, and farad. Okay, they are the 4 electrical derived SI units. 7 non-electrical SI units are Hertz, Newton, Pascal, Joule, electrovolt, watt, and Celsius. They are all non-electrical derived units. Which commonly used units are not in the SI system and how are they related? This is
Celsius.
with regard to pressure.
Kilopascal.
Millimeters of mercury, centimeters of water, atmospheric bar, Pascal, which is a derived unit. All these are used for various measurements of pressure. You can say millimeters of mercury pressure, you can say centimeters of water pressure, you can say so many atmosphere pressure, how many bar pressure and Pascal pressure. Okay? So here this is a very important point all of you should remember. 1 kilopascal is equal to 7.5 millimeters of mercury, which is equal to 10.2 centimeters of water. Nowadays, blood pressure is not described in millimeters of mercury in many textbooks. It is given in kilopascals. So if it is given in kilopascals, 1 kilopascal is equal to 7.5 millimeters of mercury. So if you want to convert 1 atmosphere, it is 101 kilopascals, which is equal to 1 bar or 760 millimeters of mercury. Okay. What is the definition of mole? The amount of substance which contains atoms equal to that in 0.12 kg of carbon 12 is the definition of mole. Amount of substance which contains atoms equal to that in 0.012 kg of carbon 12. What is Avogadro's hypothesis?
No, each
Equal volume
Molecular
of gases contain equal number of moles at the same temperature and pressure. Okay, that is the Avogadro's hypothesis. What is Avogadro's number?
6.023 into
32 point. Number of particles in 0.12 kg of carbon 12, which is equal to 1 mole, which is equal to 6.022 into 10 to the power of 23. What is the volume occupied by 1 mole of gas at standard temperature and pressure? It's a common exam.
mass by
Volume occupied by 1 mole of gas. 22.4 liters based on Avogadro's hypothesis. Oxygen molecule weight is 32. Free cylinder mass is 0.97 kg. What will be the volume of oxygen? Let's calculate. Physics நிறைய படிக்கணும் போல இருக்குல்ல. 1 mole of oxygen is 32 grams, which will occupy 22.4 liters. But the mass is 970 grams, that is 0.97 kg. That would occupy 22.4 multiplied by 970 by 32, which is the molecular weight. So 680 liters. How a E-type cylinder has 680 liters total oxygen volume calculated by this? So example on the cylinder comes in, they may sometimes ask you, how will you know that it has 680 liters? This is the formula that you have to use. Okay?
Okay, sir.
Will you stop here?
yes, sir.
Okay. You